Welcome everyone. Thank you so much for joining us today. My name is Allison Gorrilla, and I'm an outreach specialist with the UW Center for Tobacco Research and Intervention. So, in my role, I work with treatment providers to integrate evidence based tobacco treatments into their clinical workflow and program services. I'm joined today by Jesse Kaye, a clinical psychologist and researcher at UW Center for Tobacco Research and Intervention. His research aims to enhance tobacco treatment for populations who bear greater consequences from smoking, such as those who use other substances, live with mental illness or chronic pain, and those who are incarcerated. So we're happy to have him join us today for the topic we're going to present on. And our topic is on addressing tobacco use disorders and the justice involved, evidence based strategies and resources. If you're new to that term, justice involved, this is referring to individuals who've had contact or interaction with the police, courts, or criminal justice system. And when we refer to tobacco use today in our presentation, we're referring to commercial tobacco products like cigarettes, vapes, e-cigarettes, smokeless tobacco, hookah. We're not referring to the tobacco plant that is used for sacred or ceremonial purposes by some American Indian communities. And we'll most often be talking about cigarette use because combustible cigarettes are the most commonly used product among the justice involved, and they also have the highest risk to health. A few notes before we get started. If you haven't yet, we welcome you to add your name and organization into the chat box. We are going to record this presentation, so the slides and recording will be available after we're done today, and it will be posted on our website at helpusquit.org. While we're presenting, if you have any questions, we encourage you to enter those in the chat box, and we'll be addressing those questions at the end of our presentation. If you are joining, please make sure your audio is muted and video is turned off. That just helps with bandwidth. Lastly, we'd like to thank the Department of Health Services, the Division of Care and Treatment Services, and the Tobacco Prevention and Control Program for their support and partnership to make this webinar possible. And I'll kick us off with if some of you on this call may be DHS 75 providers. So the information on this slide is going to be a little bit more specific to you, whereas the rest of the content today will be broadly applicable to all behavioral health providers. So around this time last year, the revised DHS 75 code went into effect, which has now language requiring DHS 75 providers to have a written policy on their assessment and treatment of concurrent tobacco use disorders and their policy on their environmental tobacco free policy. And this revision, which includes tobacco, is really best practice for substance use disorder treatment. It aligns with ASEM's recommendations to integrate tobacco treatment into substance use disorder treatment. And it's the result of behavioral health, public health, and researchers working together for more than a decade to address this significant health inequity in the population you serve, both the behavioral health as well as the justice involved population. Our agenda for today, we have three objectives. I'm going to cover the first one and just give some background and context to why we see such high smoking rates and the justice involved. And then Jesse's going to address tobacco use as an addiction and chronic disease and some of the beliefs around tobacco use. And lastly, he's going to provide an understanding of how to support clients who use tobacco. But first, I'd like to just take a pause and bring up our first poll because we are curious what you think. Uh, pull up the question. What percent of the justice involved population smokes prior to incarceration? So if you can put in your answer there, give you a couple more seconds to put in your guess. So these are our results, and it's a little bit of a teaser right now. I'm going to share the answer in the next coming slides. So if you want to jot down your answer so you don't forget, I will reveal the answer in the next couple slides. All right. We've continued to see a decline in tobacco use prevalence in the general adult population since the 1950s, when tobacco prevalence was at around 45%. Today, only about 11.5% of adults smoke cigarettes in the US. It is one of the biggest public health success stories of the past century. However, that success hasn't been distributed evenly in the population, and tobacco use is still the number one cause of preventable illness and death. Today, tobacco use is an area of major health inequity. To bring this data a little bit closer to home, on this slide, we're presenting tobacco use prevalence in Wisconsin from our 2021 Behavioral Risk Factor Surveillance Survey. And in Wisconsin, as in the country, we've seen this continual decline. So we're currently at 13% in the general population. But as you can see, compared to the general population, tobacco use remains disproportionately high in certain groups. For example, in American Indians and in Alaskan Natives, we have 33% smoking rate. This is the highest smoking rate of any racial or ethnic group in Wisconsin. We also have high smoking rates among African Americans. In fact, Wisconsin has the largest black-white disparity in smoking of any state in the country. Low socioeconomic status is a strong predictor of smoking earlier in life, more heavily, and for a longer period of time. And so that's why you see a smoking rate twice that of the general population in lower income, as well as a higher smoking prevalence among those who have Medicaid. Lastly, individuals with mental health and substance use disorders, we know, are a population that smokes at least 3 to 4 times the general population. So it's not as well displayed here from the data from this state survey, but when we looked at a subpopulation of individuals who live in rural Wisconsin and who inject drugs, they reported a 92.2% smoking prevalence in the participants who were surveyed. That's astonishingly high compared to the general population. So let's take a look at tobacco use in our justice-involved population. Bringing back that poll, if you recall what you put, I'll share the results again. If you chose 50 or 80%, you were correct. So it's between 50 and 80% of this population that smokes. And that result has remained high and unchanged over the same time period where we've seen declines in the general population. And it's in part due to the justice involved population being overrepresented by groups with high tobacco use and tobacco use disparities. So the African American, Indigenous people of color, and the lower socioeconomic communities that I just talked about with higher smoking prevalence are also populations we see disproportionately represented in our justice involved population. For example, in Wisconsin, 1 in 8 Black men is incarcerated in prison or jail. Wisconsin leads the nation in incarcerating Native American men, with 1 in 13 working age men, Native American men in prison or jail. And in 2022, about 73% of Wisconsin individuals who are leaving prison or jail were Medicaid eligible. This is data from our Wisconsin Division of Community Corrections, which shows that substance abuse is a very high criminogenic need. About 72% of individuals are reporting a substance use disorder need, and we also know there's very high smoking in this population. So when we look at the risk factors that lead to tobacco use prior to incarceration, as well as smoking relapse after incarceration, we have to look beyond the individual level. And so there are community and societal levels that are underpinning all addictions, including nicotine addiction. And they are poverty, housing instability, lower educational attainment, lower employment, high rates of trauma and stress, and spending time in prison or jail doesn't fix these challenges. So when people re-enter their communities, they're faced with a lot of the same socioeconomic challenges that they faced prior to incarceration. But when they re-enter their communities, they have increased access to tobacco products. We know that many individuals may be returning to communities lower income, predominantly Black or Hispanic, that have been historically targeted by the tobacco industry. So they're returning to communities that might have a higher density of tobacco retailers. And you couple that with all the stress of reentry, the increased access to tobacco products, it's just a recipe for relapse. And continued tobacco use in this population is particularly burdensome because this is a population with high prevalence of chronic diseases. They're already in poor health when they intersect with the criminal justice system. They have had access to healthcare challenges their whole life. This continues after incarceration, including finding resources, treatment, and social support to remain smoke free after release. So I'm going to bring up our second and last poll. And we are curious again what you think. What percent of those re entering their community after incarceration start smoking again? Couple more seconds. Okay. So we'll reveal the answer in the next slide, but a little bit of a preview. The majority of you got it right. So close to 90%, as high as 90%, it's estimated the majority of people are going to return to smoking following release from smoke-free prisons. And I put smoke-free prisons in there specifically because the majority of our correctional and jail system today in our country has implemented some kind of smoke-free policy. So in Wisconsin, our prisons and jails are smoke-free. And when people come into them, they're forced to quit smoking. We know that forced abstinence isn't the same as treatment. And so even though someone might stay for a long sentence in prison and they may no longer be physically addicted to nicotine, so no longer in withdrawal when they're released, the majority of these individuals won't receive any kind of specific treatment that helps them to address the triggers to smoke or the risky situations that could lead them back to smoking when they're released. And so there's none of those protective relapse prevention strategies in place. Despite those challenges and barriers, the majority of people want to remain abstinent following release from prison. And we know from research we've done here in our state that the majority of individuals are receptive to receiving relapse prevention treatment, or if they start smoking again after release, they're interested in engaging in treatment to quit again. So, with that, I want to just highlight there's a great opportunity here in the community to help these clients to remain quit or to quit again. There's a missed opportunity in incarceration, but that's beyond the scope of today's presentation. So I'm going to hand it to Jesse to cover learning objective 2 and 3. Jesse.
Thank you, Allie. That was fantastic. Really appreciate it. And I think that really sets us up nicely to move into thinking about tobacco use as an addictive disorder and a chronic disease, in much the way we think of other substance use disorders. And Allie's portion really highlights the incredible health disparity and inequity that we see in the justice-involved population and the importance of addressing tobacco use and providing tools and resources to help them quit or remain smoke-free. So what we're going to do for the next section is go through a series of statements and think about in your own head whether these are fact or fiction or a myth. And then the next slide will talk a little bit about what the evidence actually suggests. So the first fact or myth is smoking is a personal choice and not an addiction. This is a very commonly held belief and a myth. In fact, tobacco use disorder is a chronic relapsing condition with both physical and psychological aspects of dependence, just like other substance use disorders. Nicotine is a highly addictive chemical, and cigarettes are a highly lethal product that will kill about half of all people who use them long term. And most people, their journey is up and down, relapsing or going back to smoking many times before they're able to ultimately quit for good. And I'd just like to note that while nicotine is the addictive substance in cigarettes, nicotine itself is not the cancer-causing agent or the cause of the majority of the harm that tobacco and cigarettes in particular instill. And we'll get back to that a little bit when we talk about nicotine replacement therapies and other medicines that can be used to treat tobacco use disorder, in many parallels to the way that medications can be used for opioid use disorder treatment. Another fact or myth, opioids kill more people than smoking. Well, if you watch the news, it would be understandable if you believe that this is in fact true. The news gives a great deal of attention, and rightfully so, to overdose deaths in the opioid epidemic that is surging in our country over the past decade. However, opioids do not kill more people than smoking. In fact, if you look at the graph here that displays the number of deaths that are attributed to different substances and other events in our country, these data are just a couple years out of date, but you can see that tobacco use far surpasses all other drugs of abuse combined when it comes to deaths. Opioids are the most common drugs for fatal overdoses. However, cigarettes and tobacco will kill nearly 500,000 people in the US every year. And particularly among clients in substance use treatment, about half will die of tobacco-related causes if they continue to smoke or use tobacco products, which is at a rate of approximately double the general population. And of these 500,000 deaths that are associated with tobacco use every year, approximately half of those come from people who are living with a behavioral or mental health condition. All right, another fact or myth. I can't repair the damage that smoking has done to my body. This, fortunately, is a myth. In fact, people can repair the damage that smoking has done to their body. And I really like this graphic here because it shows on different time scales the positive impact that quitting smoking can have on helping your body heal. In just a matter of minutes after stopping smoking or having your last cigarette, we see that blood pressure and heart rate start to come down. within the first 24 hours of stopping smoking, people's level of carbon monoxide in their lungs starts to come back down close to the level of somebody who doesn't smoke. Now, we all have carbon monoxide detectors, just like fire alarms in all of our homes. That's to detect poisonous chemicals that are unsafe for us to inhale. And when people smoke cigarettes, carbon monoxide is one of the many chemicals that is directly going into our lungs at hazardous and harmful rates. If we scan out and think about months and years, we see that after 1 year of stopping smoking, the risk associated with coronary heart disease is half of that of somebody who continues to smoke. And the rates of developing a variety of different cancers and other chronic health conditions continue to go down with the longer duration of being smoke-free. All right, another one. People in substance use disorder treatment want to quit smoking. And you'll notice that many of these facts or myths are related to substance use disorders. And that's because while we're here today to talk about the justice-involved population, we know that mental health and substance use disorders are incredibly prevalent among the justice-involved population in the country and here in Wisconsin. In fact, people in substance use disorder treatment do want to quit smoking. Anywhere from around half to up to 80% of people in substance use disorder treatment are interested in quitting smoking or changing their behavior in their relationship to tobacco use. There is not good evidence that of increased use of other substances when people are trying to quit smoking. And abstinence rates are greater for people who quit smoking for their other substances as well. So it can be a really important part of substance use recovery. People with other substance use disorders can't quit smoking. This is one we hear often, and this is a myth that we really want to dispel. In fact, people with other substance use disorders can quit smoking. About 1 in 5 have quit, and people with substance use disorders, they do have more difficulty quitting smoking than those without substance use disorder. So we're not trying to sugarcoat this and pretend like it's not more difficult, although we don't exactly know why that is. And there's a number of possible reasons. Is it because they're not provided the same evidence-based treatment that other adults in the community are provided? Is it because people are taught or believe that using cigarettes is a treatment tool to cope with withdrawal symptoms or cravings for other substances? Or are people too scared about their recovery to invest in their tobacco recovery? Quitting smoking leads people to drink more. This is not true. In fact, quitting smoking does not lead people to drink more. While we do see very high rates of co-occurring alcohol use disorder or heavy drinking with cigarette smoking, we do not see that quitting smoking leads people to relapse or go back to drinking. Alcohol increases the time spent smoking, and we know a fair amount about the neural basis where cigarette smoking actually may or quitting smoking is protective of going back to drinking alcohol among those who are in recovery. I guess I just previewed this next one. Quitting smoking can reduce the risk of relapse for other substances. This is true. Smoking can lead to relapse to alcohol or other substances. And we know that the more somebody smokes, the greater likelihood of relapsing and doing so more quickly. And there is not evidence of increased use of alcohol or other substances among people who are attempting to quit smoking compared to those who are not. And actually, contrary to previous concerns that people have had for a long time, smoking cessation interventions during addiction treatment appear to actually enhance rather than compromise long-term recovery. And related, here we see long-term mental health is improved by quitting smoking. A similar thing for other mental health and mood-related disorders as we think about for substance use disorder. Long-term mental health is improved by quitting smoking. This is for a number of different reasons. One of which being that the symptoms of tobacco withdrawal mimic or overlap many of the symptoms of mood and anxiety-related disorders, things like anxiety, irritability, anger, depressed mood, anhedonia, or this idea of having less pleasure in response to things that normally bring us joy in life. Many of these symptoms of tobacco withdrawal are the same symptoms that folks might be experiencing as a result of co-occurring mental illness. And we know that actually when people are continuing to smoke, they're going through frequent and chronic bouts of withdrawal as their nicotine levels rise and fall throughout the day and over the course of many days. And so continuing to increase their symptoms of withdrawal and mental health related symptoms while they're smoking. And as little as a month and a half or so after quitting smoking, we see that depression, anxiety, and stress related symptoms start to go down. There have been some studies that show that the effects of quitting smoking are equal to or larger than the effects of antidepressant or anti-anxiety medications when given for those conditions. And so quitting smoking can be a really tremendous intervention, not just for somebody's physical health and risk of chronic diseases, but for their mental health recovery as well. All right, so now that we've talked a little bit about tobacco use disparities in the justice-involved population and tobacco use as thinking about it as an addiction and chronic disease, now we want to impart some information about, well, what can we do about it? Give you some tools and resources that can help inform your clinical practice and public health policies. So most of the information that I'm going to be presenting on in this next section comes from the U.S. Public Health Service guideline, treating tobacco use and dependence. This serves as the national standard of care for clinical practice guidelines for treating tobacco use. And it was the result of a Herculean effort to understand the scientific, clinical, and public health literature, reviewing almost 9,000 scientific articles over the course of several decades. And this effort was spearheaded by researchers and clinicians here at the University of Wisconsin. So the framework that we're going to be using today is called the 5 A's algorithm. And you can see here in this flowchart is a really helpful user-friendly way to think about addressing tobacco use in the environments that you work in and the populations that you serve. And so we'll go through each of the A's one at a time. So the first thing that we want to do is ask about tobacco use. And so it's important to think about in your organization, where do you document tobacco use status in your intake? If you don't, it's a really important aspect to make sure that is incorporated. For those of you that are DH75 providers, this is one of the aspects that the revision that was rolled out last year requires all facilities to ask and assess for tobacco use. So because cigarettes are the most commonly used tobacco product in the country and in Wisconsin, it can be important to ask, have you smoked cigarettes in the last month? But cigarettes are not the only tobacco products out there, so it's important to ask about other tobacco products, including e-cigarettes, which sometimes people might not think about or put into the category of tobacco products. And the reason that it's so important to build this into a standardized intake document is because we know that by incorporating these systems change policies, it increases the equity in assessing and asking of all people coming into your care, and thereby increasing access and reducing potential implicit or explicit biases in the care that we deliver. All right, now that you've asked, it's important to advise providing a clear, strong, personalized advice to quit smoking. This can be tailored to whatever feels comfortable to you, but a couple examples here on the screen. Quitting smoking can actually help your recovery, so I highly recommend that we add it to your treatment plan. Or, I know that you're here to address your other addictions or substances, but this is a great time to address your tobacco dependence too, and I'm ready to help you with all of it. We know that even brief advice can increase the odds of somebody thinking about and making a quit attempt. Now we come to a crossroads. It's important to assess the person's readiness to make a change. Are they ready to incorporate tobacco use treatment as part of their substance use recovery or other behavioral or mental health treatment plan? Would you be interested in learning about some treatment options to make some changes to gain control over your smoking, focused on harm reduction and different possibilities? Are you interested in talking today about your smoking? This is something I can help you with. Are you interested in quitting? If somebody is ready and interested to quit, then we go down the path of assisting with evidence-based treatments, namely counseling and medication. So both counseling and medications are incredibly crucial components of effective and evidence-based treatment. Now, we know that there is a relationship between the amount or the intensity of counseling. We know that even just a little bit can go a long way. There's been research that demonstrates that as little as 3 minutes of counseling can help increase people's chances of making a quit attempt and being successful at staying abstinent. Not only is counseling important, but we have a number of FDA-approved medications to treat tobacco use disorder. When we think about the mental and behavioral health field and substance use space, every area is not so fortunate to have so many evidence-based medications that are approved. And we know that combining medication and counseling is more effective than either alone. So it's really important if you have the capabilities to offer both counseling and medication. So let's think about some of the basics of counseling here. First, it's really helpful and important to set a quit date. Work with the client to identify a day that they want to try to quit smoking for good. That means not even a puff on that day. Think about ways to prepare for that day, getting rid of your cigarettes, lighters, butts, ashtrays, etc. If people are unwilling to get rid of them completely, we've had a lot of creative ways we've worked with people over the years. Wrap it up in saran wrap and throw it in the back of your closet somewhere that you're not going to see it for a long time, or it makes it really difficult to get to. Just like you would do for the clinicians in the audience working with any other type of substance use disorder treatment. Let's learn from the past. What has worked well, and how can we build on that? What's led to relapse, and how can we plan for that as it relates to quitting smoking? And then, like I said, planning ahead, anticipating challenges in the coming days, weeks, and months, and identifying ways to cope with those cigarette cravings that can come on quite strongly. Identify ways to cope with cravings and provide some psychoeducation about what withdrawal symptoms to expect and ways to manage them, both with medications and behavioral strategies. Help people identify what are their triggers or what are their cues that really lead them to have a strong desire to smoke, and how can they plan to either avoid or minimize their exposure to those in the first days and weeks after quitting, or be prepared with some coping strategies for when they are exposed to those triggers. It's important to talk about your environment because we know that that has a profound impact on people's success. If it's possible to have a smoke-free home, that's always the best option. And when that's not possible, trying to work with other people in the home to see if we can create smoke-free places or zones that the person can have respite from exposure to secondhand smoke and the craving that that brings along. And then if somebody is working their treatment program or in recovery following, a harm reduction approach, if they're still drinking or using substances in some way or another, talk about the interrelationship between cigarette smoking and their alcohol use or other substance use. We know that they often will go literally hand in hand with a drink in one hand and a cigarette in the other, and talk about how that can provide a cue or a craving to smoke, and how, if possible, reducing alcohol or other substance use while trying to quit smoking is going to set somebody up for greater odds of success. A little bit more about quitting smoking during recovery. It's important to recognize the challenges of quitting during recovery. And like I said in one of the earlier slides, we know that it can be more difficult for people with substance use disorders to quit smoking. And so it's important to incorporate that into your counseling. Imparting on people that quitting smoking can increase their odds of staying in recovery for whatever substances they're working on. And that hard work can really pay off by trying to tackle both of these at the same time. Have conversations about how their smoking is related to their other substance use. What are their patterns? Do they usually use them together? Do they smoke when they can't use something else as a way to cope with cravings? And what other strategies might they be able to replace there? What recovery skills have worked in the past as it relates to alcohol or other substance use? And how can we take advantage of those lessons learned and apply it to trying to quit smoking? Because a lot of the same insights and strategies are going to be just as effective for helping people stop smoking. All right, in addition to counseling, it's important to identify other supplements or treatment extenders that can offer free resources to help people gain additional supports when they're not working with you in the clinic or in their community. The first I want to talk about is the Wisconsin Tobacco Quit Line, 1-800-QUIT-NOW. This is a free, confidential, 24/7 available service to anybody in the state of Wisconsin to receive free coaching and support over the phone any time of day. The Quit Line will also mail people a quit guide and tailored print material to help them on their quit journey, as well as a free starter kit of a few weeks of nicotine replacement therapy. That's what NRT stands for, of either patches, gum, or lozenges. And if this is something that you're interested in incorporating into your clinic workflow, my colleagues and us at the University of Wisconsin Center for Tobacco Research and Intervention can work with you to set up a fax to quit or e-referral if you don't already have something like that set up. These are options where the Quit Line will proactively reach out to your patients or clients and make a call directly to them, which we know increases referral rates on the provider side and utilization rates on the patient side. And these are systems that can be directly integrated into your electronic healthcare record system if you have something like that. Or we can work with you to set up a easy, user-friendly fax to quit workflow. There's also a number of other websites and resources that are available. Smokefree.gov is an excellent resource here in the middle of the screen. And they have a number of different apps and texting programs, as well as a wealth of information on their website. They also have tailored programs that are targeted not just for the general population, but for Spanish speakers, for adults over the age of 60, for veterans, and for women and teens. And so if you're working with patient groups or clients that fall into those demographics, they have tailored information and treatment programs for them. And importantly, I want to direct you to helpusquit.org, which is a site housed at the University of Wisconsin that has a tremendous wealth of information related to tobacco treatment resources for behavioral health, mental health, and substance use providers. All right, it's also really important to offer medication as part of tobacco cessation treatment. There are 7 FDA-approved medications that can help relieve nicotine withdrawal and craving and reliably increase long-term abstinence. We have a number of nicotine replacement therapies that come in patch, lozenge, gum, over the counter, as well as some prescription medications, both some nicotine replacements, as well as varenicline and bupropion. I want to specifically draw your attention to the 2 most effective interventions or 2 most effective medications, which are varenicline, or Chantix is the brand name, and a combination of 2 nicotine replacement products. So if you're using NRT, the best approach is to use the patch, which provides slow acting, steady release of nicotine to alleviate those withdrawal symptoms, and then ad lib formulation like the gum or mini lozenge to help people deal with those breakthrough cravings in the moment. And since many of you are behavioral health or substance use providers, there had historically been concern about providing varenicline to patients with mental health and psychiatric conditions. And I want to make sure that everybody is aware that the black box warning that was issued by the FDA many years ago has been removed, and there's no longer that warning because of very rigorous and large clinical trials that evaluated the safety and effectiveness of varenicline for patients with mental health and psychiatric disorders, and found that it is a safe and effective medication to use in this population. And so it's important to make sure that we don't have those historical or preconceived notions as a barrier to providing our patients with the most effective intervention. All right, switching gears a little bit here. So going back to the assessment, we've asked if somebody's willing to make a quit attempt, and they are not ready at this moment. For the clinicians in the audience, you probably already have the skills and tools at your side ready to help people in this motivation or ambivalence phase of change. Motivational or MI approaches are very effective in helping people move along the motivational spectrum towards quitting. You can use decisional balance exercises to develop discrepancies, asking questions about the pros and cons of continuing to smoke and of thinking about making a change. You can have conversations to address the relevance of quitting smoking to their recovery in general or recidivism factors. Discuss the potential of the rewards and benefits of quitting as it relates to their overall health and well-being and their behavioral or substance use recovery. And try to identify what are some of the roadblocks or barriers that are getting in the way of thinking about a quit attempt. In addition to some of these motivational interviewing approaches, you can also take some concrete steps if people are interested in making some change, but maybe not ready to quit completely. You can work on cutting down, reducing the number of cigarettes they smoke a day, how often they smoke. You can think about creative strategies like not smoking in certain places, like your car, your home, delaying that first cigarette of the day by a little bit and maybe extending that more over time. We know that that can be an effective way to start to reduce tobacco dependence because that first cigarette of the day is often the one that people are craving the most because they've gone all night, often without any nicotine. And so their nicotine levels are the lowest of the day. And you can combine some of these strategies, for example, using nicotine replacement products while they're still smoking. It's important to know that these are safe products to use while somebody is still smoking. And so you can incorporate strategies such as using a mini lozenge or a nicotine gum in a place that somebody has identified as somewhere they want to try to cut out smoking. So in their car, popping a lozenge in instead of smoking a cigarette is a great way to start to use both medication and behavioral strategies in conjunction for somebody who's not quite ready to quit completely. Now, the final A is to arrange follow-up. Just like you would for any other mental health condition or substance use disorder, it's important that we continue to work with our clients. We know that tobacco dependence is a chronic condition and ongoing support is key. And so multiple contacts are better than a single brief intervention. As we start to wrap up here today, I want to leave you with a few takeaways. First, that tobacco treatment is an important part of treatment and recovery for individuals who are involved in the justice system, who have other mental health or substance use disorders. That most people who use tobacco are interested in changing their tobacco use, and they can do so, especially when provided with evidence-based treatment. This is an incredibly important component of reducing the tobacco-related inequities that we see in the justice-involved population. And behavioral health and substance use providers have the skills already to provide tobacco treatment combining medication and counseling to help your patients and clients stop smoking. We're here to help. If today's webinar has increased your interest in learning more, I want to make sure you're aware of a wonderful website that my colleagues have developed, helpusquit.org. This was developed in partnership with the Wisconsin DHS, the Division of Care and Treatment Services, as well as the Tobacco Prevention and Control Program. And we are here to assist you. Make sure if you're a DHS 75 provider that you are adhering to the requirements. And we have some really wonderful toolkits that focus on creating a tobacco-free environment and integrating tobacco treatment into behavioral health care settings. It has a host of resources, including videos, worksheets you can use with your clients, print materials for educational purposes, case studies, and a variety of tools. If you want to do a little bit more training and education on your own, from this website, you can get to a number of other resources and ongoing continuing education related to general tobacco treatment training, the bucket approach training, which is specifically targeting providers who work with adults with mental illness in their quit smoking journey, and training for the administrative and public health type folks out here, thinking about systems change and how to make changes within your organization to improve the culture of tobacco treatment. And finally, our last slide here, you've already met Allie, and we've also got Sarah, Susan, and Amy on the line today. These are our outreach specialists at the University of Wisconsin Center for Tobacco Research and Intervention, and we are here to provide you and your organization ongoing, individualized, and free training and technical support to help you develop the skills and tools to implement tobacco treatment in your facility and make the systems change that's going to set your organization up to serve your clients as best as possible. And so with that, we will finish our presentation and happy to open it up for questions or discussion.
Thank you, Jesse. I see we have a question from Latigra, and let me just open the chat. It went away. Are you familiar with information about NRT use during pregnancy? Jesse, do
Um,
you want to take that one or?
Sure. Yeah, it's a great question. It's a really complicated topic. Working with people who are pregnant and smoke is challenging. There are a number of great resources and some organizations here in Wisconsin that specifically work with women and people who are pregnant to provide a smoke-free start to the baby's life, primarily focusing on behavioral and counseling and peer support services. The NRT medications, because we know that nicotine can affect the fetus, they generally are not FDA approved for use during pregnancy. And so many clinicians will be hesitant to prescribe or recommend NRT during pregnancy, as that's contraindicated. That said, many providers will have more nuanced conversations with their patients to discuss the risks and benefits associated with nicotine itself versus all the other harmful chemicals that and toxins and carcinogens that the pregnant person and fetus are exposed to by using cigarettes or other tobacco products. Allie, do you have anything to add there?
No, that was great. I'm just going to add that the Wisconsin Women's Health Foundation is a great organization for more information. They have the First Breath program that you were referring to. And we did a webinar in July on this topic. It's available at helpusquit.org that will provide more information on the types of treatments that can be offered during pregnancy and how to kind of navigate that complicated issue with NRT. So if you're interested, that we'll have a little bit more information as well.
That was a great question. If anybody else has any questions, feel free to pop them in the chat, and Allie and I are more than happy to do our best to answer them for you.
And I also want to quickly add that when you exit the webinar, you'll see a 4-question survey. We're really interested in your feedback, what you thought of today's webinar. So please take 30 seconds to fill that out. Again, we really appreciate your feedback. I'm gonna put our contact information in the chat, or my email, and Jesse, if you want to put yours as well, in case someone doesn't want to ask a question now, they can contact us afterwards.
Yep, that sounds good. And I also just reshared that in the last screen. So depending on where you live in the state of Wisconsin, if you're in the southeast region, you can contact Allie. If you're in the south or south central or southwest, Amy Store. Oops. Just skip through all the slides. There we go.
Great, thank you. Well, Jesse, if you want to just type yours in too, in case. Thank you. Well, thanks so much, everyone, for joining us today. It was great to have you on, and we appreciate your attention. And have a great rest of your day, everyone.
Thank you.
Thank you.